A 63-year-old postmenopausal woman with stage 2A, T2, N0, M0, grade 2, ER positive, PR positive, HER2 negative, invasive ductal carcinoma underwent lumpectomy and radiation. She was initiated on anastrozole 1 milligram daily. 6 months later, she reports debilitating joint pain and stiffness affecting her daily activities, unresponsive to regular NSAID use. Anastrozole is considered a suboptimal initial choice for adjuvant endocrine therapy in this postmenopausal patient. Answer: false. Aromatase inhibitors, including anastrozole, are genuinely preferred over tamoxifen as initial adjuvant endocrine therapy for most postmenopausal women with HR-positive breast cancer, due to improved outcomes demonstrated in clinical trials comparing these agents. The patient's symptoms are highly unusual, as musculoskeletal side effects affect only a small minority, less than 5%, of women on AIs. Answer: false. AI-associated musculoskeletal syndrome, including arthralgia and joint stiffness, is a common side effect, potentially severe in up to 1/3 of patients and leading to discontinuation in 10 to 20%. If the patient discontinues anastrozole due to intolerance, switching directly to tamoxifen is the only recommended next step? Answer: false. Before switching to tamoxifen, temporarily discontinuing the AI followed by initiating a different AI, example letrozole or exemestane, is a reasonable strategy, as nearly 40% may tolerate the alternate AI. Is initiating duloxetine a recognized management option for this patient's persistent AI-associated arthralgias after NSAIDs and exercise have failed? Answer: yes. Duloxetine demonstrated improvement in joint pain compared to placebo in the SWOG S102 trial for patients with AI-associated joint pain and is considered an appropriate option if initial measures prove insufficient. Should acupuncture be dismissed as a potential therapy due to lack of any supporting evidence in AI-associated musculoskeletal symptoms? Answer: no. While benefits observed in a randomized trial were numerically small, acupuncture did show statistically significant improvement over sham acupuncture or weightless control for joint symptoms and can be considered, especially for patients preferring non-pharmacological options. If this patient had pre-existing degenerative joint disease, would it exclude the possibility that her current symptoms are related to the anastrozole? Answer: no. A significant number of women who develop AIMMS have pre-existing musculoskeletal conditions, suggesting these conditions do not preclude AI contribution to symptoms. A 69-year-old postmenopausal woman completed 5 years of adjuvant tamoxifen for a stage 2B, T2N1, M0, grade 2, ER+, PR+, HER2 negative breast cancer diagnosed 5 years ago. She tolerated tamoxifen reasonably well, experiencing only mild hot flashes. She presents to discuss options for further risk reduction given her prior node-positive disease. For patients like this woman with node-positive disease, the risk of distant recurrence essentially disappears after completing 5 years of endocrine therapy. Answer: false. Observational data, including a large meta-analysis, show that the risk of distant recurrence for ER-positive breast cancer continues steadily for at least 20 years after diagnosis, particularly for those with node-positive disease. Continuing tamoxifen for an additional 5 years is not an effective strategy for reducing recurrence risk after an initial 5 years of tamoxifen. Answer: false. The ATLAS and ATTM trials demonstrated that extending tamoxifen to 10 years, an additional 5 years, reduced the risk of recurrence and breast cancer mortality compared to stopping at 5 years. Switching to an aromatase inhibitor like letrozole or exemestane for 5 years after completing 5 years of tamoxifen offers no proven benefit over stopping endocrine therapy. Answer: true. Trials like MA.17, letrozole, and NSAPB33, exemestane, showed that switching to an AI for 5 years after 5 years of tamoxifen improved disease-free survival compared to placebo. Is extended endocrine therapy generally recommended for consideration in patients with prior node-positive disease who have completed 5 years of initial endocrine therapy? Answer: yes. Due to the persistent risk of late recurrence, especially in higher-risk patients, including node-positive disease, extended endocrine therapy beyond 5 years is an option often pursued. Does the available evidence suggest that an AI is definitively superior to continued tamoxifen in the extended adjuvant setting after an initial 5 years of tamoxifen? Answer: no. While cross-trial comparisons might suggest AIs could be slightly more effective, they have not been directly compared to tamoxifen in the extended setting after initial tamoxifen, and both strategies show benefit over stopping therapy. Should the breast cancer index be routinely used to determine if this patient requires extended endocrine therapy? Answer: no. While BCI may be considered selectively, particularly in lower-risk patients facing uncertainty, it is not routinely recommended for decision-making, especially in patients with clearly higher anatomic stage, like node-positive disease. A 66-year-old postmenopausal woman underwent mastectomy for a 5.5 centimeter, grade 3 ER-positive, PR-positive, HER2-negative invasive ductal carcinoma with 5 positive axillary lymph nodes. She completed adjuvant chemotherapy and is initiating endocrine therapy. Her oncologist discusses adding a CDK4/6 inhibitor. The addition of a CDK4/6 inhibitor, like abemaciclib or ribociclib, is definitively proven to improve overall survival in the adjuvant setting for high-risk early breast cancer. Answer: false. While trials like Monarch-E, abemaciclib, and Natalie, ribociclib, have shown improvements in invasive disease-free survival, IDFS, follow-up is relatively short, and a statistically significant overall survival benefit has not yet been demonstrated. This patient meets the high-risk criteria for consideration of adjuvant abemaciclib based on the Monarch-E trial eligibility. Answer: true. The Monarch-E trial defined high risk as having greater than or equal to 4 positive nodes or 1 to 3 positive nodes plus either tumor size greater than 5 centimeters, histologic grade 3, or Ki-67 greater than or equal to 20. This patient meets the criteria with 5 positive nodes and also with tumor size greater than 5 centimeters and grade 3 disease. Adjuvant palbociclib demonstrated similar efficacy to abemaciclib and ribociclib in large phase 3 trials for high-risk early breast cancer. Answer: false. The Pallas and Penelope B trials, which evaluated adjuvant palbociclib, failed to show an improvement in IDFS and were stopped early, Pallas, or reported negative results. Is adjuvant olaparib the preferred targeted therapy addition for this patient instead of a CDK4/6 inhibitor? Answer: no. Olaparib is indicated for patients with deleterious germline BRCA mutations. There is no information provided about this patient's BRCA status, and CDK4/6 inhibitors are considered based on clinicopathologic high-risk features in the absence of a BRCA mutation or if BRCA status is unknown or negative. If ribociclib is chosen, should it be administered continuously alongside endocrine therapy for 2 years? Answer: no. Adjuvant ribociclib, based on the Natalie trial, is approved for 3 years and is given on a schedule of 400 milligrams daily for 3 weeks, followed by 1 week off. Adjuvant abemaciclib is given continuously for 2 years. Are grade 3 or higher adverse events significantly more common with the addition of abemaciclib compared to endocrine therapy alone? Answer: yes. In the Monarch E trial, the incidence of grade greater than or equal to 3 adverse events was substantially higher in the abemaciclib plus endocrine therapy arm, 50%, compared to the endocrine therapy alone arm, 16%. A 71-year-old postmenopausal woman completed 5 years of letrozole following surgery and radiation for a 1.2 centimeter grade 1 node-negative, ER-positive, PR-positive, HER2-negative invasive ductal carcinoma. She tolerated letrozole well apart from mild vaginal dryness managed with moisturizers. She asks if she needs to continue endocrine therapy longer. Extended endocrine therapy beyond 5 years is strongly recommended for all patients with ER-positive breast cancer, regardless of initial stage or risk factors. Answer: false. Extended therapy is an option, but the decision requires balancing recurrence risk against side effects. For women with smaller node-negative tumors, low risk, the benefits are less clear and may not outweigh toxicity risks. Continuing letrozole for an additional 5 years, total 10 years, has been proven to significantly improve overall survival in postmenopausal women who completed an initial 5 years of AI therapy. Answer: false. While the MA17R trials showed that extending letrozole for 5 more years after approximately 5 years of AI improved DFS, no trial has demonstrated an overall survival benefit for extended AI therapy after an initial 5-year AI course. The risk of bone fractures is expected to decrease if this patient continues letrozole for an additional 2 to 5 years. Answer: false. Extended AI therapy is associated with increased bone-related toxic effects. The MA17R trial showed higher rates of fractures, 14 versus 9%, and new-onset osteoporosis, 11 versus 6%, with extended letrozole versus placebo. The ABCSG16 trial also showed more fractures with 5 versus 2 years of extended anastrozole. Is it considered reasonable for this patient, given her low-risk disease features and good tolerance, to stop endocrine therapy after 5 years? Answer: yes. For women with smaller node-negative tumors, stopping endocrine therapy after 5 years is a reasonable option, particularly if they wish to avoid ongoing side effects and risks, as the absolute benefit of extended therapy is likely small. If this patient strongly desires further risk reduction and is tolerating letrozole well, would continuing it for an additional 2 years, total 7 years, be an appropriate consideration? Answer: yes. If extended therapy is chosen for low-risk patients, an additional 2 years, total 7 years, is considered appropriate as the benefits of extending to 10 years appear minimal in this group while toxicity risks persist. Are gene expression assays like the Breast Cancer Index routinely recommended to guide the decision about extended endocrine therapy for this specific patient profile, low anatomic risk? Answer: no. While weak recommendations exist for potentially using BCI, routine use is not endorsed, especially as a primary driver for decisions. It might be selectively used to aid discussion if the patient is uncertain despite low anatomic risk.
A 57-year-old woman was diagnosed with stage 2A, ER+, PR+, HER2-negative breast cancer. She received adjuvant chemotherapy, completing it 10 months ago, and has been amenorrheic since chemotherapy. Prior to chemotherapy, she had regular menses. Her oncologist wants to start an AI, but needs to confirm her menopausal status. Amenorrhea for 10 months following chemotherapy in a 57-year-old woman is sufficient by itself to confirm postmenopausal status for the purpose of initiating AI therapy. Answer: false. For women under 60 experiencing chemotherapy-induced amenorrhea, amenorrhea for greater than 12 months and serial estradiol and FSH levels in the postmenopausal range are required to confirm menopause, and amenorrhea alone, especially for less than 12 months, is unreliable. Aromatase inhibitors are equally effective in suppressing estrogen whether ovarian sumption is present or absent.
Answer: false. Aromatase inhibitors work by blocking peripheral conversion of androgens to estrogens and are inactive in women with intact ovarian function. Ovarian suppression or ablation is necessary if AIs are used in premenopausal women. If menopausal status cannot be definitively confirmed, initiating tamoxifen would be an inappropriate choice for this patient. Answer: false. Tamoxifen is effective in both premenopausal and postmenopausal women. If menopausal status is uncertain or confirmed premenopausal, tamoxifen is a standard endocrine therapy option or an AI combined with ovarian function suppression. According to NCCN criteria, is age greater than 60 years old considered a sufficient criterion for defining menopause in women with breast cancer? Answer: yes. The NCCN definition of menopause includes age greater than 60 years old as one of the criteria. Can menopausal status be reliably determined in a woman currently receiving ovarian function suppression therapy, example goserelin? Answer: no. Menopausal status cannot be determined in individuals actively receiving ovarian function suppression, as the therapy itself alters hormone levels. Is prior bilateral oophorectomy sufficient to define a woman as postmenopausal for treatment decisions? Answer: yes. Prior bilateral oophorectomy is one of the explicit criteria for defining menopause according to NCCN guidelines. A 68-year-old obese, BMI 36 kilograms per meter square, postmenopausal woman is 2 years into adjuvant exemestane for stage 2A ER-positive, PR-positive, HER2-negative breast cancer. She reports increasing fatigue, difficulty concentrating, and admits to occasionally missing doses over the past few months because she feels unwell. Her last bone density scan showed osteopenia. Obesity, BMI greater than 35 kilograms per meter square, has been consistently shown to have no impact on breast cancer recurrence risk in postmenopausal women receiving adjuvant endocrine therapy. Answer: false. Some data, such as a post-hoc analysis of the ATAC trial, suggests that a higher BMI, greater than 35 kilograms per meter square, is associated with a greater risk for recurrence despite endocrine therapy, although not all studies confirm this association consistently across all populations. Fatigue and cognitive difficulties, forgetfulness, are not recognized potential side effects of aromatase inhibitor therapy. Answer: false. Studies have reported higher rates of cognitive problems and identified fatigue and forgetfulness as predictors of AI discontinuation, indicating they are recognized potential side effects. Missing occasional doses of exemestane is unlikely to have any clinically significant impact on treatment efficacy or outcomes. Answer: false. While data specifically linking adherence levels to breast cancer-specific mortality are limited, studies suggest low adherence, less than 80%, increases all-cause mortality risk, and one study linked biochemical non-adherence to tamoxifen with shorter distant DFS. Therefore, maintaining adherence is stressed as important for maximizing treatment impact. If switching to an alternative AI, anastrozole or letrozole, a reasonable strategy if exemestane is poorly tolerated due to fatigue or cognitive symptoms? Answer: yes. Individual patients may tolerate one AI better than another, and switching to an alternative AI is a reasonable approach if the initial one is poorly tolerated and other management strategies fail. If this patient permanently discontinued exemestane 6 months ago due to side effects, would restarting adjuvant endocrine therapy, either the same or a different agent, potentially offer any benefit? Answer: yes. Data from the MA.17 trial, restarting letrozole after placebo, and a Swedish registry study show that restarting adjuvant therapy after discontinuation was associated with improved DFS. Does the development of osteopenia while on exemestane necessitate immediate cessation of AI therapy? Answer: no. AI-induced bone loss leading to osteopenia is a known side effect. Management typically involves monitoring, lifestyle modifications, calcium and vitamin D supplementation, and potentially bone-modifying agents rather than immediate AI cessation unless severe osteoporosis or fractures occur refractory to management.